I would like to thank the iBank Association of India and the Asia Pacific Academy of Ophthalmology and AIS for giving me this opportunity. So like Dr. Basak has said, Nepal has a very beautiful journey for iBanking, and I would like to say I have no conflict of interest and no financial disclosures. So in Nepal, why did we actually need an iBank? Because it's a very small country like Bangladesh, but it is not so heavily populated. So we found that we also have a very large burden of the global blindness. And when we did a survey, and what we see in the survey in 1981, the blindness was about 0.84, and in 2010 and 12, when the RAB survey came, it was 0.35. But if you see the number of blind, they are nearly the same. It's not very different. And when we see the causes for blindness, the corneal blindness in our part of this country was about 6%, and corneal blindness in children was quite high. It was about 45%. And because it is an agricultural country, even though people are doing many other jobs now, but still corneal trauma and corneal ulceration was the major cause for corneal blindness. So this journey of Nepal iBanking actually started from 16th of September 1994, when the first iBank was established, which was situated in the Tilganga Institute of Ophthalmology, and it was inaugurated by our prince, who is not there anymore. There was an assassination, this thing, in the royal family. And now today our iBank is actually recognized for very good quality of corneal tissue, and also as a training center for the iBankers. So this Nepal iBank today is associated and accredited by the SightLife, the EBAI, the EBAA, and now I think the Cure Blindness is also in the scenario. So initially, like Bangladesh, even Nepal was dependent on other countries for their corneal donations. So we used to have very little corneal donation, and like we used to nearly get about 243. You can see the data there. We used to get these corneas from outside, and see I think this is something very different. Our iBanking was, or it is still known as the temple iBanking, because the crematoriums, we have the Pashupati Nath temple, which I think everybody knows about it, and it is situated on the rivers of Bagmati river, and that is where the cremation normally in Hindu religion it takes place. So we used to actually go and ask the dead persons, the kin and the relatives, to please donate. So that is how this temple iBanking, the name came, because it is at the rivers of the Bagmati near Pashupati Nath. So you can see the Pashupati Nath temple there. But then slowly what happened, it was becoming very difficult to get corneas by asking them, because they put a lot of abir, or this is actually the vermilion which they put when somebody dies, and the corneas were getting like they were not very good quality cornea. So we had a little bit of more challenges. So we thought that we should go for other systems. So initially, like when we started, we didn't have the iBanking system was not very good, because we didn't have many trained corneal surgeons. We didn't have any national strategy for about nearly 10 to 15 years when it was started. And like we said, it is already only dependent on the voluntary donation, and it was limited only to the community awareness and education for this iBanking. So now then what we thought is, what should we do? So we thought that we have to eliminate this blindness, and our mission was actually to establish a National Eye Center for iBanking as per with the International Eye Standard. So we set a goal of about 1,500 plus corneal transplant were needed. So what we did is, we got accreditations for this small iBank from the International Tissue, from the American iBank Association, from the iBank Association of India, and also from the SightLife. So now when we see this journey, now so what has happened is, in 1994 we started the iBank, we partnered with the Lions and the Rotary, then we had this Temple iBank, we partnered with the SightLife, and when the SightLife actually came, we started with the hospital cornea retrieval system. And that is where the university hospital where I work. So in that, from that particular hospital, which is the Tribhuvan University Teaching Hospital, we are nearly collecting now about 700 to 800 to now even 1,000 corneas in a year. And these are all good quality corneas. So now we have a lot of surplus tissue, like it's going to the foreign countries. We are doing this pre-cut tissues also for DALC, for DSEC, DBEC, and also we have now started the amniotic membrane. So we have now entered into a new phase from to the hospital cornea retrieval system now, which is in conjunction with the crematorium-based or the temple eye banking, and also some of these contributions from the voluntary eye donations. So this is my hospital where we excise, or we take the whole globe also, or we take the cornea. So our EDCs are there. They do a very good job. So these are our different hospital from where we can collect corneas. The one from where we take the maximum number of corneas is the teaching hospital. We also have the Beer Hospital, the cardiac centers, the Patan Hospital, and from the electric crematorium, which is now working very efficiently from where people are donating. And like already Dr. Basak has said, we have a lot of partnership and support from the different eye hospitals in Nepal, all over, from the different zones and the regions. And we also have collaborations with the different societies and the trust, like the Pashupati Trust. We have the Nepal Cornea, Cataract and Refractive Surgery Society, the Nepal Ophthalmic Society, the Eye Donation Society. So we have a lot of these organizations which are helping us. And now, like we said, we started with a very small number of corneal tissue, that is 2. Even when we started HCRP, we just had about 6 or 7 tissues we got. But see, today now we have nearly crossed 1,500. So now we are aiming for even more so that we can help our own corneal blind people, and we can also, we are actually giving it outside, and surplus is giving outside also. But I think the problem that we are having in Nepal today is we are still struggling with therapeutic keratoplasties and full thickness. We are doing DMEC, not so much of DMEC and DSEC or DALC, because I don't know, we are still struggling with that part. And because most of our corneal surgeons are actually so busy doing cataract surgery, they are not doing their corneal surgeries. So like we have different parameters to evaluate for eye banking. And we have our own values, which is, it is also dependent on accessibility, sustainability, and awareness and education. We have a very good awareness and education for eye banking. I'll so the current scenario is that we have a tissue processing fee for our tissues when we send them outside, or even to the corneal surgeons outside, which is very minimal. It is not the corneal tissue, but it is actually only for the processing fee. So that way the eye bank is able to sustain. And like we said, we also have these the eye bank is supported by the banks also, because it is under the corporate social responsibility. So the banks are supporting eye donation societies there, social support from different social organizations. So I think Nepal Eye Bank is doing a very wonderful job, and we are able to sustain ourselves. So our sustainability is based on 3 principles, which is economic, environmental, and social. And we also have an informal sustainability in the form of profits, planet, and people, because we need profits to sustain our eye bank actually. So like for this sustainability, it's very important that we are utilizing our tissue, which is maximal utilization, and we use this tissue for research and training whenever required, and the disposable is done according to the WHO standard, which is very important. And even the economic sustainability, like I said, we are asking for a processing fee, not for the tissue. So we have the government policy where under insurance policy, the transplants are paid by the government, and there is no commercial value for these tissues. We don't have actually any legal form of any binding, or we don't have any license, that type. Like in India, I think you cannot transport your tissue or export your tissue. So till date, we don't have that. So I don't know, maybe we have to do that, or we don't have to, because if we do it, then we'll not be able to send it to Bangladesh. So we don't have that type of system in Nepal till now. Our legal system has not taken that into account. And like we said, we are very self-sustainable. HCRP is doing a very wonderful job. And social sustainability, like we've been doing a lot of awareness and education. And I think because it's Hinduism plus Buddhism, and in Hinduism, I think that was the first slide which I told to everybody. Whenever the transplant was done, Lord Shiva himself transplanted the head of his own son Ganesha with an elephant head. So we are the first transplant people in Hinduism, whether it is Bharat Varsha or whatever. So I think that is way people are quite, like they are quite aware, and they want to donate now. So they come to us, so we have these papers, so it's very good. So I think that is all I have to say. So we have a very good banking, and people are totally doing it on humanitarian basis. Thank you so much.
Thank you, Dr. Meenu, for excellent presentation, and we are definitely looking forward much more work from the Nepal Eye Bank. As such, it is highly commendable. And things it starts with the PK only, and I think that depends upon the demography, the type of cases you get it. Yes. If it is a rural area cases where the injuries and infections are the predominantly engaged, obviously the PK is there. And second step will come and the tertiary when you switch over to the DSEC and DMAC. Yes, for sir. That you can take help of
yes,
any.
Yes, sir. Dr. Samar Basak
yeah,
has come.
Dr. Sir,
Sir,
that's
actually,
I was telling. You can take it help from the
yes.
this Dr. Basak. You can take it from the PGI,
yes.
RP Center.
Yes.
And when you have mentioned about the Virat Nagar, I have a nostalgic memories of working in these areas through the armed forces medical services in 1987-88.
Okay.
I was stationed in Dharan and doing the cataract work as well as promoting the eye banking and other activities.
Okay. Sir, actually, I think our surgical training for cataract is quite good. So even PBK is not so common. PBK, Fuchs dystrophy is very less. So
one of my students from the Nepal army, Ramesh Bisht.
Okay, yes, yes.
I trained him in FMC way back in 98-2000.
Yes, he's there.
What is the utilization rate, Meenu?
Utilization is nearly 80%.
80%.
So this data is for only Nepal Eye Bank or through the country?
No, this Nepal Eye Bank data is from everywhere, the whole of the country.
So this is like
because
a society,
we
like
send
EBAI,
our reports.
you have a society for
Sorry?
Nepal? Like EBAI, you have a central body for Nepal?